We'll now proceed to the cyanotic lesions, which are the right to left shunts, keeping in mind that when we get to the mixing lesions, that can also be cyanotic. One quick way of remembering cyanotic heart disease is to the 5 T's and a P. So look for tetralogy of Fallot, that's cyanotic, truncus arteriosus, that's cyanotic, transposition, cyanotic, total anomalous pulmonary venous return, cyanotic, and tricuspid atresia can cause cyanosis. And the 1P that we've discussed already is pulmonic stenosis. So even though that was a stenotic lesion, pulmonic stenosis, if there's some kind of communication, an ASD or a VSD, then blood can shunt across and you can get cyanosis. The first one we're going to discuss is the tetralogy of Fallot. This is the most common congenital heart disease to cause cyanosis. Okay? And these are the 4 components of tetralogy of Fallot. A pulmonary stenosis, it's not really the valve that's stenotic. It's the area underneath the valve, the infundibulum, that is stenotic or hyperreactive. And depending on the degree of stenosis and or hyperreactivity, that will determine the amount of cyanosis that is occurring. So it's not the valves themselves, it's just below it. You also have a ventricular septal defect and an overriding aorta. The aorta sits on top of that VSD. It's shifted over just a little bit so that when the right ventricle pumps, it meets that infundibular stenosis, and blood, as always, takes the path of least resistance. It goes across that VSD and it goes up that overriding aorta and to the systemic circulation. Only problem is that blood has not had a chance to go to the lungs to pick up oxygen yet, and that's why you get cyanosis. Because the right ventricle is doing so much work, not so much pumping against the infundibular stenosis, but pumping against a systemic vascular resistance, you get right ventricular hypertrophy. So those are the 4 components of the tetralogy of Fallot. Some people describe what's known as a pentalogy of Fallot. It's good for a party, a little trivia, and that would be an associated ASD. So here we see a nice diagram. This is the infundibular stenosis, or the pulmonic stenosis. So the pulmonary trunk will be a little bit narrowed. The blood meets resistance, and so it takes the path of least resistance, and it goes across this VSD, and there's the aorta, and that's less resistance too. It shoots up this way, hasn't had a chance to go up to the out to the lungs yet. And you're going to get right ventricular hypertrophy simply because that right heart is working so hard. So you do have a right ventricular outflow tract obstruction and shunting and cyanosis. Again, if you have a mild infundibular stenosis, you may have adequate blood flow to the lungs, and so you oxygenate well, and that's what we call a pink tet. So we have blue tet and pink tets. A pink tet has enough blood flow to the lungs. Given enough time, however, the pink tet will eventually become a blue tet. If you have a severe obstruction, you will notice cyanosis in the immediate newborn period. Another thing to remember, another concept, is what they call the paroxysmal hypercyanotic attacks. They're also known as blue spells or tet spells. And that occurs when that infundibulum, for whatever reason, really gets reactive and it clamps down and it causes increased resistance to blood flow to the lungs, and so you get more shunting. In the old days when we didn't operate at such an early age, you would notice the child would be maybe playing and then they would squat. And when they would squat, they would increase the pulmonary vascular resistance, they would increase the systemic vascular resistance and make it harder for blood to go across that VSD and up to the aorta and out, and it would kind of make the blood go more towards the lungs. We do the same thing with infants nowadays. If they're having a hypercyanotic attack, what we do is we just scrunch them up and put them in the knee-chest position. That increases the systemic vascular resistance and kind of makes the blood go a little more towards the lungs. On exam, you will hear a harsh systolic ejection murmur. That's your VSD. Also remember, since you have this infundibular stenosis, it's a single S2. You don't hear the typical S1 and S2 or the splitting of S2 because the pulmonary outflow tract is obstructed, and so you're only going to hear one S2 sound. Also look for what's known as the characteristic core and sabot or the boot-shaped heart on X-ray. They will either mention it or they'll show you an X-ray. We're going to show you one in a minute that shows that up-tilted apex, the boot-shaped heart. Also, the lung fields will be fairly black because there's decreased blood flow to the lungs in your classic tetralogy of Fallot. If it's a pink tet, they might have some improved pulmonary blood flow and markings. On EKG, you'll find right ventricular hypertrophy, and obviously the best test is an echocardiogram. So here you have a classic X-ray of the tetralogy of Fallot. This is the up-tilted apex. It's a boot-shaped heart, looks like a ski boot almost. And look how black those lung fields are. That's not because they over-penetrated the X-ray. Those are black lung fields because of the fact that there's decreased blood flow to the lungs from that right ventricular outflow tract obstruction. You want to treat these patients for any heart failure. Nowadays, the surgery is a lot earlier than it used to be because the techniques are better and so the results are better. Certainly before the surgery, you are at higher risk for cerebral thromboses and brain abscesses. Since these patients are hypoxic, they will have very high hemoglobins or hematocrits. It's not unusual to see a hematocrit of 75, 80%. That's really thick, sludgy blood, so they are at risk for clotting and also for abscess formation. Patients are at risk for bacterial endocarditis, but heart failure is not seen that often anymore because we're operating on them at an earlier and earlier age. And if certainly initial treatment might be to keep that ductus open so that you do get some blood flow to the lungs, and the definitive therapy is going to be surgical correction. Tricuspid atresia a lot of times almost looks like a tetralogy of Fallot, similar type of findings as far as there's no blood flow to the lungs because since there's tricuspid atresia, there's no blood, very little blood going from the right atrium to the right ventricle, and so very little blood is being pumped from the right ventricle out to the lungs, and so you may have a single second heart sound also, like you do with the tetralogy of Fallot. So if you have no blood going from the right atrium to the right ventricle, you have to have another connection of some sort, and so many times blood goes to the left side of the heart via a foramen ovale or an atrial septal defect. Then the blood can go out systemically. The pulmonary blood flow will depend on the size of the ventricular septal defect, and a PDA, a patent ductus arteriosus, also helps pulmonary blood flow initially. So go back to the drawing of the fetal circulation and you can work this out. We're going to show you here what happens. If you have a tricuspid atresia, there is no blood flowing from the right atrium to the right ventricle. So blood needs to actually go across a patent foramen ovale or an ASD. That way it gets into the left atrium. And from the left atrium, it can go into the left ventricle. And then what happens is you need an ASD for the blood to get from the left ventricle to the right ventricle and then out to the lungs. So that's how you can bypass it. So you need to have other heart defects to help you out. A ductus arteriosus is helpful because then in that case you can have shunting across this level and then blood can get to the lungs that way. Usually these babies present with severe cyanosis at birth. The left ventricular impulse will be increased because the left ventricle is basically doing most of the work. You may not hear a murmur because of possibly no real gradients. Certainly the test of choice is going to be an echocardiogram. If you see a baby that is cyanotic and has left axis deviation on an EKG, then you should think of tricuspid atresia. That means that the blood is shunting to the left side of the heart. The treatment initially is to use prostaglandins to our advantage. We talked about indomethacin being a prostaglandin inhibitor and closing the ductus, where we use prostaglandins to our advantage to keep the ductus open so at least there's some communication so that the blood can get to the lungs. And then it's going to need, the patient will need surgery, and usually it's a couple of surgeries that need to be done. Ebstein's anomaly is a downward displacement of the tricuspid valve. So we went from a tricuspid atresia where there's nothing to a downward displacement of the tricuspid valve. It makes for a larger right atrium and it makes for a smaller right ventricle. And you will have, with mild to severe Ebstein's anomaly, it will look like a tricuspid atresia. The chamber will be thin-walled and you'll have right atrial enlargement just because it's physically somewhat bigger and it's going to have to work a little harder. And you will have blood shunting across from the right atrium to the left atrium through a foramen ovale or an ASD. And so that's how you get cyanosis. Here we see a different displacement of the valve, and so you're going to have this Ebstein's anomaly with the right atrium here, the right ventricle then is not the proper size. You're going to have all different kinds of blood flow problems, and you need to have communications between them so that you can have some oxygenation. Ebstein's anomaly depends on the severity of the anomaly, determines the presentation of the symptoms. Again, in a newborn, they can be cyanotic from birth and have an enlarged right atrium. And here is a baby with an enormous heart due to Ebstein's anomaly. It's not a characteristic necessarily X-ray, but it's a huge, huge heart. You can see it's taking up most of the chest. That means this baby is going into heart failure very, very quickly. You'll hear a holosystolic murmur. You can hear a gallop rhythm from the failures. And certainly you can see the big heart on X-ray. Sometimes you can have some conduction anomalies such as Wolff-Parkinson-White, or they can actually have supraventricular tachycardia, and that exacerbates the heart failure. You're going to go ahead and get an echocardiogram, and you start them with prostaglandin so you have some kind of communication. Everybody has a ductus, and you want to keep it open in this case. We're now going to discuss a couple other cyanotic lesions. The transposition of the great arteries. This is the most common congenital heart disease to cause cyanosis in the first 24 hours of life. Tetralogy of Fallot is the most common cyanotic one. Transposition presents very quickly with cyanosis. Then they go into heart failure very quickly. Remember your normal circulation. What happens with transposition is that the aorta comes out of the right side of the heart. So the right side of the heart, the right ventricle, is basically pumping deoxygenated blood back out to the body. The pulmonary vessels are coming out of the left side of the heart, so the left ventricle is pumping blood back out to the lungs. So basically you have, it's like two parallel circulations. As opposed to being in series, they're now in parallel. And so you have to have some kind of communication or it'd be lethal. It wouldn't happen even in utero, it wouldn't work. So somewhere along the line, you have to have an associated either a VSD or an ASD or a ductus. You have to have one of those three. Now, one of the things that you're going to do for these patients is you're going to start them on prostaglandin, because you may not know if the patient has a VSD, you may not know if they have an ASD, but everybody is born with a ductus, and so you want to keep that one open at least until you can get other things done. So these patients require some kind of connection. They're going to get cyanotic very quickly. They're going to go into heart failure very quickly, so your chest X-ray will show a big heart. You can see it over several hours. You can see it actually getting worse if you take serial X-rays. It's also common in infants of diabetic mothers. Here we see the problem. There's your aorta coming out of the right side of the heart, so deoxygenated blood is going back out to the body. Here we see the pulmonary vessels going back out to the lungs, but where are they originating? They're originating from the left ventricle. Many times they'll have this foramen ovale or an ASD, and certainly you'll see a ductus. So that's why we want to keep the ductus open so that there's some mixing of blood. The blood will then go to the lungs through the ductus until you can do definitive repair. As the ductus closes, they're going to get worse. And you can, again, on physical exam, many times hear a single-second heart sound. If there is a VSD, you will hear the harsh murmur of a VSD. The best test, obviously, is going to be an echocardiogram, but an EKG can show some right-sided predominance, which may not be too dramatic. The chest X-ray will show an increase in pulmonary blood flow and an enlarging heart. They describe what's known as the egg on a string. I'll show you a picture in a second, and it's because of, it seems to be narrower at the top because of the change in the relationship of the major vessels as they come out of the heart. So if you can use your imagination, here's the egg laying on a string. Now, if you can see that, you can probably become a radiologist yourself. Takes a little bit of imagination. The initial treatment is going to be to start prostaglandin to help keep the ductus open. Sometimes the next step would be a balloon atrial septostomy, where they basically just make a hole and create an ASD before they, to at least cause some mixing, and eventually it'll be complete surgical repair. There's various ways of doing it. You will not get asked about atrial switches and things like that, or arterial switches.